Good afternoon, my dear students. Today we are going to discuss urinary system in children, anatomic and physiological peculiarities, methods of objective and additive inspection, and semiotics of main disorders. Today we are going to discuss everything about anatomic and physiological peculiarities, methods of inspection which include collecting the complaints and analyzing anamnesis morbi and anamnesis vita. And all other points of this topic you will be listening to in part 2 of the same lecture. So let's start. As far as we are going to discuss kidney today, urinary system, so let's discuss first functions which are typical for this organ. First of all, that is regulation of constancy of fluids volume in the organism. We can call it volume regulation, and osmotic active substances concentration regulation or osmoregulation. Ionoregulation is typical, acid-base balance regulation, excretion, metabolic regulation, and incretion. Urination starts its formation on the 9th week of gestation. It's quite early, but taking into account this peculiarity, anyway, placenta is the main excretory organ in fetus. There are 3 main stages of kidneys intrauterine development, which are pronephros stage, mesonephros stage, and metanephros stage. Gradually, kidneys are changing their location from pelvic part into intra-abdominal one. It happens approximately on the 7th week of intrauterine development. And on the 9th week of gestation, they are already placed higher than aorta's bifurcation. If to discuss postnatal peculiarities, we may say that up to 7 to 8 years of life, kidneys are located quite low, as they are relatively large and the lumbar part of vertebral column is relatively short. Due to this peculiarity, it can be clear why in more skinny hypertrophic children, kidney may be palpable up to the age of 7 to 8 years. But I will repeat, the child should have a low amount of subcutaneous fatty tissue. And then, due to low position of the kidney, they may be reached their palpation. Secondly, kidney's mass at birth makes 10 to 12 grams. It increases twice up to 6 months of life and 3 times by the end of the first year of life. To 15 years, it increases for 10 times. Kidneys in children are segmented. The cortex is underdeveloped. And kidney's tissue at the same time is soft. Connective tissue, septi, are expressed quite poor. Up to 2 years of life, the nephron has a very weak differentiation. The visceral part of glomerular capsule consists of cuboidal epitelium, which complicates the process of filtration. Renal channels are significantly shorter, and their lumen is 2 times more narrow, which can contribute to urine absorption decreasing. There is tight connection between renal lymphatic vessels and intestinal lymphatic vessels. It may explain easy spreading of the infection from intestines into kidneys with the following development of pyelonephritis. Diameter of ureters is larger and they have several curves, which also may contribute to easier development of the infection. Urinary bladder is small in small children, is localized higher and may be easily palpable. Urethra length in boys makes 5 to 6 centimeters and reaches 10 to 12 centimeters in pubertal period. In girls, urethra is shorter and makes 1 to 2 centimeters. It may explain, it's one of factors why urinary tract infections, especially urethritis and cystitis, are more common among girls rather than in boys. It's larger in diameter as well, and it has a practical value in catheterization and cystoscopy carried out in girls. And now let's discuss anatomical and physiological peculiarities of urination. There are three levels of urination regulation, which are: first one, lower level. It is presented by the detrusors, urinary bladder muscle, internal and external sphincters. Urination is provided by the detrusors contraction and synchronous relaxation of sphincters. Disorders on this level of regulation are mainly caused by lower urinary tract infections or anomalies. Second level, and that is middle level, it is presented by urinary bladder peripheral innervation and spinal centers of urination regulation. Sympathetic part of a spinal center is responsible for urine holding and parasympathetic one for its expulsions. Disorders of regulation on this level are connected with residual and organic or infectious pathology of spinal parts of central and vegetative nervous system. And finally, high level. It's represented by cerebral centers located in medulla oblongata, hypothalamus, frontal and parietal parts of the cerebrum. Therefore, urination disorders on this level reflect organic and functional pathology of brain cerebrum, higher vegetative centers, and are closely connected with systemic neurosis in children. And we are moving to methods of clinical investigation. As it is common for working with any system or organs and systems of organs, we always start with gathering complaints of the child. That is the first step in our work. Secondly, after we have detailized all basic complaints, because complaints may be numerous in the child and they may be related to affection of different organs, because sometimes there is complex disease which is not limited by affection of only one organ. So your aim is to understand what is the basic system to be affected in this child by detailizing complaints, by understanding which complaints are leading ones and which ones are additive, which testify to the affection of concomitant and other organs. And after you have understood which complaints are related to basic system which is involved into pathological process, you need thoroughly detailize them. Detailization includes some gathering more particular features of this certain complaint. For example, if we're talking about headache as being the basic complaint of the child, you need to find out more thoroughly what is a certain localization of this pain. Does it irradiate or it doesn't? The time of the day when it's the most remarkable, character of pain, which remedies help to provoke or to improve condition of the child by reducing this pain, and so on and so forth. These details, these particular characteristics will be helpful in making the diagnostic algorithm more narrow. First of all, and in some cases, they will help you even to guess the diagnosis already. After gathering complaints and after detailizing these complaints, you move to anamnesis. These are two types of anamnesis. The first one is anamnesis morbi, and basically it should answer the following questions. When the first symptoms have arisen? Secondly, what could be possible provoking factors? It may be overcooling, it may be stress, there may be physical overloads, and so on and so forth. The next question, either the child had already received some kind of treatment, and what was the dynamics of basic symptoms on the background of that treatment. Sometimes we deal with chronic pathology. That's why if it's not the first episode of the disease already, you need to find out how the disease in general was developing during the whole time of its presence in a child. For example, how many hospitalizations were, and what was the treatment, and what was the effectiveness of this treatment. Probably different methods of diagnostics had been carried out. You need to find out what they were and which results had been received thanks to these methods. And after that, you finish with anamnesis vitae, or anamnesis of life. It's very profound, and it consists of many different positions. We will explain it thoroughly in our practical classes, but generally it includes information about different allergies, family anamnesis, bad habits. It also involves information about the labors and the first year of life, physical development, neuropsychal development. Also it includes information about infant infections, children's infections, and the rate of the respiratory viral diseases in the child per year, for example. Either the child is often sick with different diseases or he is not. Also, it includes information about social and economic condition and how the child is successful at school, the child's behavior with his classmates, group mates, and family members as well. And some particular features typical for each system of organs. So let's start with complaints related to urinary system affections. What should we be particularly interested in? First of all, pains in the lumbar area. Second, urination disorders. Presence of edemas, headaches, vertigo, dizziness, fever, vision disorders, nausea, vomiting, poor appetite. And let's discuss pain syndrome. If you found out that the child has pain, what should you particularly find out about this pain? First of all, localization. Localization may occur in lumbar area, and it will be typical for different sorts of nephritis. It may be localized projection of ureters or suprapubical area. If it's localized in suprapubical area, it's more specific for cystitis, which is inflammation of the urinary bladder. Second thing you should find out about pain is either it's irradiating or it's not. Character of pain. What can it be? It can be dull, for example, when it is caused by distension of kidney's capsule. And those diseases is typical for are acute glomerulonephritis, pararenal fat abscess, cardiac decompensation, or congestive kidney it's also called, chronic pyelonephritis, and chronic glomerulonephritis. It may be also sharp and acute. It may be present in acute pyelonephritis or renal colics. Next, characteristics which should be detailed about pain, that is, conditions which contribute to pain appearance. And these conditions may be abundant drinking, jolty traveling, or urination. And here I would like to mention such pathological symptom which is described by a term strong urea, which means painful urination. If the child is experiencing pain while urinating, that means that the child has strong urea. Urethritis, which is inflammation of the urethra, is also characterized by a feeling of burning in the urethra in time or immediately after the urination. Another parameter which should be found out about pain is remedies which decrease pain and improve condition of the patient. Why is it important to find them out? Because they may give us some suspicion on the origin of the disease. For example, if there is vivid effectiveness of spasmolytic drugs, it means that this pain is caused by spasms. Sometimes the effect may arise from the use of a hot water bag or warm baths. Usually it also testifies to the origin, which is caused by spasm. Changing of body position sometimes may improve condition of the child and reduce the pain. It may be in case of nephritis and paranephral abscess. Applying of a bag with an ice to lumbar area may improve condition of the child with paranephral abscess. Analgesic drugs intake. When the child's condition, child's pain is improved by analgesics, it testifies to urinary colic attack. Disorders of urination. That's another block of complaints which is very typical for urinary system problems. It may manifest itself either in changing of general quantity of urine discharged during a day or changing of a daily rhythm of urine discharge as well. And here we need to understand, to clarify some conceptions in order to understand disorders of urination. And the first of them is diuresis. What is diuresis in general? That is a quantity of urine discharged during a certain period of time. For example, if this is a quantity of urine calculated during 24 hours, we're talking about daily diuresis. If we're talking about the quantity of urine which is discharged during daytime, we're talking about day diuresis. And if that is a quantity of urine discharged during night hours, we are talking about night diuresis. Diuresis may be positive or negative. Positive diuresis, that is when there is the quantity of urine which is discharged is significantly more than consumed quantity of fluids. And negative, that is when everything is vice versa. The quantity of consumed fluid during, for example, daytime is significantly more than that one which is finally discharged with urine. So positive diuresis is present in case of fading away of edemas and if the child, for example, was taking diuretics. And negative diuresis is typical for edemas when they are formed. Hot and dry environment. Dysuria is a term which describes disorders of urination. Different disorders of urination are related to this big syndrome, dysuric syndrome. I would like you to understand it well because sometimes this term is confused with the term stranguria, which means painful urination, but it's not. Dysuria characterizes urination disorders. And here we have different sorts of these disorders. For example, polyuria. Poly, the word means more than it should be. Urea, urination. That is diuresis increasing 2 times and more in comparison with an H norm. And the reasons of this condition may be abundant drinking, cardiac and renal edemas fading away, diabetes mellitus, diabetes insipidus, compensator 1 in chronic renal failure development, and in recovering from an acute renal failure. Oliguria, that's vice versa, that's decreasing of daily quantity of urine for 1/4 or less of normal one. I would like to remind you that lection on periods of childhood and transition conditions of newborns, we have discussed that oliguria during first 1 to 3 days of child's life is considered to be absolutely normal physiological event. And if we're talking about pathological reasons, that may be insufficient introduction of fluid, fever due to increasing of perspiratio insensibilis with breathing, and not just breathing, actually by sweating as well, vomiting and diarrhea, cardiovascular failure due to edemas formation, acute renal failure, and at the beginning of nephritis development. And anuria, that is almost absent of any urinations here, and that is actually defined as decreasing of daily quantity of urine for 1/15 of normal one. And 2 main forms of anuria are excretory and secretory. What is excretory anuria? That is when urine can't be discharged due to some blockage in urinary pathways, like stones, significant edema, or tumor. But production of urine is not violated. It's produced, but due to some blockage, due to some violation on the pathway of its discharge, it can't be normally removed. So usually it is accompanied by significant, sometimes colic-like pain in lumbar area and ureters projection. And secretory anuria, that's violation of urine secretion from kidneys. So the urine is not normally secreted. And it's typical for severe forms of acute nephritis, nephronecrosis, incompatible blood transfusion, severe form of cardiac failure, shock, massive hemorrhages, and also it may be of refractory character in severe pains in case of trauma, fractures, and in other pathological conditions. Another dysuric signs include ischuria. That's condition when a patient is not able to empty his or her urinary bladder due to spinal marrow compression or trauma, unconscious state. Pollakiuria, I ask you not to confuse it with polyuria. Whereas polyuria is increasing in the volume of the discharged urine, pollakiuria is often urinations, is increasing of the frequency of urinations. And they are present not only during the daytime, but at night as well. Isuria, that is discharging of equal quantities of urine with equal intervals in case when kidneys lose their ability to regulate urine's quantity and concentration in dependence on drunk fluid quantity, physical load, temperature of environment, and other factors influencing a water balance of the organism. It's typical for chronic renal failure. Nocturia, that is increased rhythm of urinations at night accompanied with increasing of night diuresis. Normally in general, and we